went over the screw home mechanism, and last
I'll take a look at it closer.
lab,
We'll
we
figure it out.
finished off range
But yeah,
of
sounds good.
So, this is a video I posted on the screw home mechanism. I'm hoping you guys got something out of that.
Lower extremity, de-locking mechanism.
So this
Locking
is how
mechanism occurs in the last 30 degrees of flexion extension, most evident in the last 5 degrees.
It's pretty intense.
Femur on tibia, closed chain movement, lateral view. Femur rotates internally, medially to lock. Femur rotates externally, laterally to lock. Locked. Unlocked. Femur on tibia, anterior view. Locked. Unlocked. Tibia on femur, open chain movement, lateral view. Tibia externally, laterally rotates to lock. Tibia internally, medially rotates to unlock. Locked. Unlocked. Tibia on femur, anterior view. Locked.
I guess you guys get the point, right? The one thing that they didn't describe, which you guys should be able to, and if you can't, then just revisit the PowerPoint presentation, the screw home mechanism slides. It doesn't talk about what structures cause the locking and unlocking. It tells you what's happening. But again, keep in mind the roles of the meniscus, the cruciates, and the popliteus. Also consider the terms roll, spin, and glide. Okay. Today, we are here. So again, there's no lab on Monday. There's no classes on Monday at all. Next Tuesday, we'll continue with the pathology presentation, and then the labs next week will focus on special tests. Okay. And then this week there are no classes. We're just doing OPs. Just to give you an idea, or to give you an idea of what the OP exams are going to entail, they're strictly just skills. Okay, so you're not going to do a whole 30-minute start to finish. It might be a little bit of history taking. What I'll probably do is I'll give you a picture or a model will be here. And we'll take a look at some things that jump out, and we'll see if you can find some of those things on the model. And then I'll ask you to do specifically ranges of motion. I might ask you what they mean, so what symptoms come up and what those symptoms mean. And I might ask you to demonstrate specific special tests. Okay? So it'll be very regimented, if you will. Okay? Now, on the CAT exam, it's basically it's essentially assessing a patient from start to finish. Okay. With this exam, I'm going to ask to see certain things. Okay. And that way, you'll have more practice over the entire semester. Practice a whole assessment from start to finish. Okay, I just kind of want to see where your hands are at right now, and your observation skills, your range of motion testing skills, your special testing skills first. Okay, before we put it all together. So that's the expectation for that person.
And is that just the knee and the ankle that we're
Strictly
testing?
lower leg.
Okay.
Yeah.
And so, like, scanning and clearing, is that part of it as well?
Potentially that's going to be included in the range of motion testing.
Okay.
But I'll ask you. like I want to see you do a scanning exam.
Okay.
Okay, the decision to scan or clear, we'll practice that through the entire semester before I ask you to do that on the final OP.
Okay.
So it's a little bit different. Any questions about what to expect with that first OP? Okay, so special test. What we'll do, I normally do it this way. If there's another strategy you prefer, just let me know. Email, or you can fill out that course evaluation survey that I put on Blackboard for each class, just to give me an idea of what you prefer. I normally show about 4 or 5 special tests in a row. We'll talk about it, I'll demonstrate it, and then I'll let you guys practice for about 10 minutes. And I might even call you guys up to test it on me so I can tell you whether you're putting the appropriate forces, hand placements, the right direction, and so on. Okay. Ideally, I would have some alumni come in and sit there for you, so you can do it on them and they can give you feedback. But again, early Monday morning and Friday is not the best time to get alumni to come in. But you can always do it on me. So the first bunch of special tests deal with swelling. Some of you have done this on me already. This is the brush sweep test, brush test, milking test. There's different names for it, but it's for intracapsular swelling. ACL meniscus. So you brush the medial side, brush the lateral side. Now, in most books it says brush up and then brush down. So go up medially, go down laterally. On my knees, you can actually just push directly on top of the area on the medial side and then push on the lateral side, and you should see the fluid move from one side of the knee to the other. Okay. This next one is called bilateral patella. Apply slight pressure or tap over the patella. A positive if the patella bounces. Okay, that's what it says. In my mind, balancing is and that's not what's going to happen. It'll feel different bilaterally. One will be able to sink in more, so it'll feel like it's sitting on a cushion of water. And in the case moderate to severe swelling. Moderate to severe extracapsular swelling. If the kneecap is extracapsular.
Is the knee a small extension?
Typically. If there's a lot of swelling, you'll even feel the difference with slight flexion. So for those first two, just turn to the person beside you. For this lab, you're going to need shorts. So if you need to change, you'll have a few minutes to change. But just try those first two. That's pretty simple. You don't really have to get on the table for this. But just do the sweep test and the lateral patella. Pretty straightforward. Does anybody have excessive swelling in their knees that we can play with, aside from myself? Okay.
Super cool.
Does anybody else have intracapsular swelling?
One of my kneecaps is
Yeah, it's not going to happen.
If you haven't done intracapsular swelling or seen it, you can come up and do it on me.
Oh, so you can.
In the middle. I'll go in the hallway. We're going to take it right here.
whatever.
Okay.
Let's super tap.
I don't like on the I wonder if it's like so
So much is going on that you can't even see it.
Sweep test and the laudable patella. Just give you a couple minutes to do this one. This shouldn't take too long.
You also just move your stuff. I could do it.
If you want to try intracapsular and see it as well, see a positive, you can come up and...
I know. I was trying to sneak in, and then I was like, yeah, no, my ID card's at home. Can't sneak in. So what do we do with it?
I've never had
Yeah,
it.
that's fine.
No, I put it on the field.
Every time I work out. What's the other one?
Okay, that one's
It's just muscle now. Oh man, I hope that's good.
You trying to find that?
Okay, the next bunch are what McGee calls uniplanar tests versus rotational or multiplanar. And so in the knee, we're specifically going to test MCL, LCL, LCL, ACL, PCL. The first one, anterior posterior drawer test, hip at 90 degrees. Sorry, hip at 45. Sorry, so when it's written like this, hip slash knee, it's 45 at the hip, 90 at the knee, respectively. To be drawn anterior or posterior positive test. You just need to be aware of a false positive because if you have a PCL tear, it'll already sit in a posterior position because the PCL isn't there. And then if you draw forward, it'll look like it's actually moving a lot. Okay? So you need to be able to differentiate between a positive anterior drawer and a false positive anterior drawer. Anything greater, and this is done by what's called a KT1000. How many of you have heard of a KT1000? It looks like a barbaric device. You put your knee in it, you grab this metal handle, and you pull it. And there's a little ruler on the side of it that measures how much anterior translation results from you pulling on that handle. What you're looking for is laxity, but with an ACL rupture, you're looking for an end field, an abrupt stop. And if there is no abrupt stop, it feels boggy, then that's positive. Okay, so that's your anterior drawer. Positive indicates these things. Just realize there's a lot of things. And a lot of times this doesn't happen in isolation. A lot of times if you have an ACL, you might have some of the posterior lateral corner stretched as well. Considerations. Abnormal starting position, that was the false positive I was talking about. This is specific for the anterior drawer. A false starting position, it might be due to a torn PCL. Gravity, hamstrings, joint diffusion, all these things could get in the way of your testing. We talked about how the hamstrings guard, so they'll spasm. Contrastingly, if you will. What's the muscle that shuts down? VMO. So one muscle will shut down, another one will spasm. Okay, and in this case, it would be the hamstrings. So just what a lot of people do with the anterior is they try to relax the hamstrings. They'll kind of like slap it around and they'll kind of jiggle the leg a little bit to help them relax. But a lot of times you can't really control that. So just things to be aware of. Okay? Lockman's test, slightly bent, 20 to 25 degrees. In some books it'll say 30 degrees. The tibia is drawn anteriorly. The positive test, anterior tibial translation, but this is the big one again, absent end feel. You should feel an abrupt stop, and if you don't, if it feels boggy, then that indicates that the ACL is completely torn. Indicates ACL sprain, posterior oblique ligament, and arcuate popliteal complex, which is a combination of those different. So on the anatomy slides, there is the arcuate popliteal complex, and there was a list of all these ligaments underneath that complex. Okay. One of the ligaments, the main ligaments, is the arcuate popliteal ligament. So that ligament and this ligament is your posterior lateral corner, essentially. What is posterior lateral bundle. Okay, so if the knee is more in an extended looking position, you're going to test the posterior lateral fibers. Whereas with the anterior drawer, with the knee bent at 90 degrees, you're likely to get the anterior medial fibers. If there's no end field, the person is torn both. Okay.
So an extension, you get more posterior laterals.
Generally speaking, Lockman's is a little bit of a better test because it has the leg in a more relaxed position. The hamstrings don't guard that well in an extended position. Lockman's test, some considerations: improper femur stabilization. So again, you have to stabilize the one side of the knee while you move the other. It's the tibia that you're moving. A meniscus lesion would get in the way, so the person might feel pain, and they might complain of pain before you even get to the end feel, which means that the test you can't do. And then tibial interrotation, okay, which means you have to interrotate the tibia to loosen the joint a little bit more to get a better test. Modifications, this is based on the size of the patient's legs, the size of your hands, what type of table you have. There's some tables at your placements that you can't raise or lower, or you might be doing it on the ground. Okay, so there's some things to look out for. Drop leg, stable, prone reverse, and active no touch. I'll demonstrate those in a second. Those are just some variations of the Lockmans that you can potentially use. We'll do all the ACL, PCL tests first, and then I'll demonstrate, and then I'll have you guys practice. Posterior sag, this is just an observation. You don't do anything with this. They're just sitting there at 90 degrees. 90 degrees deflection, 45 at the hips. And if you compare bilaterally the tibial tuberosities or the tibial plateaus, if one is sinking in more, then that's already an abnormal starting position, which means that the PCL has probably been stretched, which also means that your ACL might have a false positive. What you're looking for is this thing called a sulcus sign. Okay, so your tibial tuberosity should actually be a bump. It should be convex. If it's concave, that's a sulcus sign. Again, PCL, arcuate popliteal complex, posterior oblique ligament, and anterior cruciate ligament. Godfrey's test is exactly the same. It's just the person's at 99, hips at 90, and knee at 90 degrees. Oh, sorry. So you just have to hold their feet up so that they're relaxed. What's the difference between this position and this position? More gravity. Okay, the limb's not resting on the table anymore. Okay, when you lift up the limb, the leg is heavier. The lower leg is heavier, so you might get a better indication.
There's a drill at UST who tortured PCL, and some of the seniors came up to us and they were like, "Just touch your knee." And same thing, like, we didn't really see it with the posterior side, but we did this one, and really
Good.
and we also did get the false positive on that anterior drawer. And before we did this one, we're like, "Oh, PCL." We did that. And
Would you ever come in for a TIMIs? What team?
rugby.
Like another option for those of you who, I guess with STS, you guys are required to go into the institutions if you guys want to visit University of Calgary. Rugby might be worth taking a look at there. So, anyway, Godfrey's test and posterior sag are both for PCLs. And again, you'll look for the sulcus sign. Indicates posterior instability, PCL tear, or a stretch or laxity in the posterior lateral corner. Okay. This other stuff is we'll do that later on. Okay. Any questions about those tests? So we got Lockman's, anterior drawer, and the posterior drawer, sag and Godfrey's. Are you guys familiar with the modifications? So what you'll see most people do with the anterior drawer is they'll sit on the person's foot, look for the medial outer plateau, put your thumbs on it, and then draw forward. What I do is depending on how painful this is for the person, I'll do it slowly first to see how much translation I can get, assuming that the hamstrings are relaxed. And depending, if it comes out, if it's kind of suspect, I'll do a little bit of a, as long as it's not painful for them, because I'm looking for that abrupt stop. I've seen other people do it this way with their elbows, and that's another way to do it as well. Has anybody done any other different type of body position to the anterior door? But those are the two that I've seen. Okay. Godfrey's, posterior sag, you're just taking a look. Godfrey's is that one, just holding the leg up and taking a look. And then posterior drawer, same idea, but you're just pushing back, assuming that it's at the same starting position. Okay. If you already see a sulcus sign with this, I don't think it's absolutely necessary to do an actual drawer. I mean, if you want to do a drawer to see how far back it goes to confirm, you can probably do that as well. But the posterior drawer position, they're starting off in this position anyways, which is, it's still a PCL test. Lockmans. Okay, so slight bend, relax. And it's easier if they're on their elbows or laying down, but she's not relaxed. I normally turn it out a little bit, but then when I grab the tibia, I get a pretty good grasp. And again, the same thing, depending on how they're reacting, I'll go a little bit slow. Feel that? Okay, so at the end, if you, like, you know when you take a belt and you kind of snap it, you should feel that at the end if you do a quick lockness. And that's the abrupt stop we were talking about. Okay, so that's the traditional way to do it. The other way, other modifications, you put your leg up. Sorry, I'm not flexible. But if the person has small hands and the person's thigh is too big to get your hand all the way around, what some people will do is they'll use their leg to mimic their fingers, and they'll just put their hand on top to stabilize above and below, on top and underneath the femur, and then they'll do their translation this way. So that's another option.
What if your hand's too small to hold the flounder?
Good question. What do you do? There's other modifications as well. So the drop leg, I guess the best way to do this, slide forward. Tapping your elbows. It's not a very good grip. Okay, so take your leg off to the side of the table, and just drop your leg and put it between your knees. Okay, and you do this. Okay, so there's still that snap at the end. I like this one the best. Like, I find I can get the abrupt end feel this way compared to all the other ways. The prone reverse is they're on their stomach, but which way are you pushing the proximal part of the tibia out if they're prone? Sorry?
Into the bed.
You have to push down, right? So the Lockman's in this case. So I tend to hold this like a headlock in here, and I'll push down. I don't like this one, but it's another option. Okay. And the last one is active and no touch. So active and no touch, and I think this works only the best if it's really torn. If they try to extend their lower legs, so if they contract their quads, think about where the patella tendon inserts. What should happen to the tibial plateau if they try to kick up into my hand? What should happen to the tibial plateau? Move forward or move back? It should move forward because the insertion is on the anterior surface of the tibia. So if she contracts, the patellar tendon will translate the tibia anteriorly, actively. So she'll do it. I'm not even pulling. I'll just hold this down. I'll ask her, can you contract this? And if I see this come up a little bit relative to this side, then that's a positive. What do you think will happen? First of all, if you want to test PCL, what muscle would you have to contract and what would you see? Hamstrings? What would you see? Posterior translation. You'll see an accentuated sulcus sign. So if I go like this, and I say hold that position, and that actually sinks in, which it will. A friend of mine that played softball at University of Florida, she actually had a torn PCL, and every time she did, and she was able to play without it reconstructed. She would do hamstring curls, and every time she pulled down, sulcus sign each time. But that's what the hamstrings do. They'll pull back on the proximal part of the tibia. Quads will do the opposite. It'll drop anteriorly, proximal part of the tibia. Okay. So, try those 4. We got anterior posterior drawer, posterior sag, and Godfrey's. And then try some of the modifications with Lockmans. Once you're done and you're waiting, practice on somebody else. 10 minutes. Again, try as many different positions as possible. Hand positions, I mean. Lauren, do you want to partner up? Or do you want to watch a little bit first?
The drop. I can never get
Like laterals or deep.
Laterals?
Why not? Can you show this one to me again? We just got
There's a lot of effort, exhausting. You just dropped it. And then just
Okay. I'm just gonna watch it. Not doing any
Yeah, what was that? Relax.
I can't.
Are we gonna check?
Oh, that's great.
Yeah, maybe a little bit louder, that's pretty good.
If somebody finds a good Lockman, let us know.
I wish somebody had an ACL.
You guys? Well, Andrew.
He went skiing and then he caught an edge or something and cartwheeled down the hill.
Into your colon.
Yeah, he's